Okie dokie. So
Yeah.
if we move on to the next slide, please. Going well. Anyway, if there were people from what the wider partnership got some questions, which we could send out anyway, and a link to the Microsoft forms for people to feedback to us. So I'll just move straight on to the setting the scene. So we're here today really to think about winter readiness, how it matters, and to explore some of the programmes. So Holly and colleagues have already mentioned some of the work that they're doing, but we are going to cover the Asthma Friendly Schools project, the Too Much Blue campaign, hear a little bit more about the social prescriber link worker and what they've been up to in the new programme. And we're just really pleased to have you here, and if you wouldn't mind staying around at the end for the poll, so that we can capture some of the feedback and what would make a difference in terms of future asthma planning for North East Lincolnshire. Next slide, please, which I think is handing over to Marcia. So over to you.
Hi, everybody. So yeah, if you can go to the next slide, please. So really, I just wanted to talk initially about why it's important, because I think everybody knows somebody with asthma. And I think when a condition is so common, we can all get a bit blasé about it. We can consider that it's something that's easily managed, that we're generally doing a good job at managing it, and we can forget that it can actually be a serious condition, and also the scale of the problem. So in terms of our children and young people, asthma is the most common long-term medical condition. 1 in 11 children in the UK have asthma, and that's properly diagnosed asthma. So that's not even taking into account all the preschool wheezers and all the children that potentially don't have it properly diagnosed yet. Now, the reason it's important for us to look at it is that although we consider ourselves to be a great medical care system in the UK, we're actually doing worse than anywhere else in Europe. In terms of having good asthma control, low admissions to hospital, and low rates of death from asthma. And things haven't really been improving. In 2015, we had the National Review of Asthma Deaths, and they looked in great detail at every death from asthma, and came up with lots of recommendations for how we could change practice. But although everybody was shocked by the outcome of that report, it hasn't really led to sustained change, which has made a difference. Asthma outcomes are poor across the board, and certainly our poorest population are the worst affected. And that will be for lots of reasons that we'll talk about throughout the presentation. And when we think about our core 20+5 population, and as we know in adults and children, we're looking at this core 20+5 population. So the most deprived 20%, and then 5 key clinical conditions. And for children, asthma is one of those conditions. The most deprived 20%, will be disproportionately affected by asthma, and asthma is one of the key areas across the board that we need to be looking at. Next slide, please. So in terms of child deaths due to asthma, so this is from the report in 2024, there were 54 deaths due to asthma between April 2019 and March 2023. And I think I'd like to pause here, because 54, you might think that doesn't sound like a huge amount, and certainly compared to many adult conditions, it doesn't. But when we think about 54 families that have lost a child due to a condition which effectively is able to be controlled in the vast majority of cases with treatment and environmental changes, that's a tragedy. Each one of those deaths is a tragedy. What we know is that 15 to 17-year-olds are the group with the highest death rate. Now, this surprised me, because I would have thought it would have been younger children, maybe more vulnerable children, you would view them as less strong in their constitution. But actually, we know that there's real issues around that transitional age in asthma, where children are suddenly expected to take more responsibility for taking for their own asthma care. Often their parents are chucked off the GP systems in terms of ordering the medications for them, and they can tend to run into more difficulties because they're less concordant with medication, and also lifestyle changes such as smoking or vaping can affect. Children from deprived areas are 4 times more likely to die from their asthma. 87% had 3 or more reliever inhalers dispensed. Asthma's generally traditionally controlled, although we're moving away from that, traditionally controlled by preventer inhalers, which are taken twice a day, or reliever inhalers, once or twice a day, or reliever inhalers, which are taken when the child has symptoms. The problem is that traditionally there's been an over-reliance on those reliever inhalers. And although they make the patient feel better there and then and can help in an attack, they don't actually deal with the underlying airway inflammation. So they won't actually help with the overall asthma control. And certainly what we know from the National Review of Asthma Deaths is that over-reliance on pure reliever inhalers that don't have any preventer in them is one of the key risks for death from asthma. All the children that died have been exposed to air pollution above WHO guidelines. And WHO guidelines can be different to the guidelines that we have here in the UK. 27% were born before 37 weeks gestation or with a low birth weight. And that's interesting, was that a direct effect of them being a low birth weight and lungs being affected by that? Or could it be because parents are more likely to be smokers and then the smokers in the home and you've therefore got an increased risk of developing asthma? And then there's also themes from CDOT reviews: pets in the home, poor indoor air quality, smoking by family members, and no personalised asthma action plan in place, and poor communication within services. Next slide, please. So in Humber and North Yorkshire, we've got this prevalence of 3.1% of children and young people have a diagnosis of asthma. So that seems lower than what we've been told on other figures of up to 11%. I mean, I suppose that's a prevalence perhaps at the moment, whereas some children's asthma could have resolved. But to me, those figures don't seem quite right. I'd be interested to hear what Jen thinks about that later. The highest rates are seen in North and North East Lincolnshire, and the lowest rate is in York. So again, sort of a correlation with deprivation, although perhaps we'd expect to see more in Hull. And asthma is often underdiagnosed, so we know it's underdiagnosed. And there's lots of reasons for that historically. It's often due to sort of read coding in GP practices. There were historically some issues around access to diagnostic tests like spirometry, which meant that GPs were reluctant to code children with asthma because if they didn't then have access to the diagnostic test, they would be penalised financially at the end of the year. So sometimes they'd try and put other codes on, but then the problems with that is it can mean that the children don't get called for review every year, and our prevalence data is incorrect. Next slide, please. So asthma triggers and vulnerability. So we've talked about air pollution. Particularly here, I suppose we're referring to outdoor air quality. And we know that sort of schools that are in areas where there's poor air quality, children in those areas, particularly walking to and from school, are more likely to suffer from asthma. And asthma will also worsen if the air quality is particularly poor. So already our children that are within those urban areas are going to have a disadvantage, particularly if they're diagnosed with asthma already. Then we've got housing vulnerability, damp, mold, insecure housing conditions, just generally not living in a nice, warm, clean home is going to increase those sort of environmental triggers that can affect asthma control. And fuel poverty as well. This is a real issue for us in North East Lincolnshire. People who cannot afford to heat their homes are more likely to get mold, damp issues arising, and therefore more asthma exacerbations. Next slide, please. So this is quite an old map, but I think it's quite interesting because it shows us that actually in terms of particulate matter, despite us being near the coast, and you might think that we would have quite good air quality, we have got some issues with particulate matter across the area, and we've also got issues with sulfur dioxide, particularly in the Immingham area, probably I would imagine due to all the industry there. But children in those anecdotally, I've had a lot of children come to Grimsby from Immingham, move practices and move and say that the asthma control has improved significantly moving from Immingham to Grimsby. So certainly, these particles and chemicals in the environment could be triggers for some, if not all, children. Next slide, please. So we've got lots of housing vulnerability in North East Lincolnshire. I mean, you know, in 2020, fair enough, it was a fair while ago, but 13,353 households living in fuel poverty then. I would like to bet that's gone up now. I don't know what anyone else thinks. And you know, the cost of fuel has gone up, you know, and generally inflation and has gone up so much since COVID. So I could imagine that we've got many more families than that now living in fuel poverty. And thinking when we look at the figures of our families who live in IMD decile 1, children disproportionately, they're in a higher amount of the households living in IMD decile 1. So we know that children sort of disproportionately represented in those households. So there's going to be a lot of children in those 13,300 households who suffer from asthma. Next slide, please. And it's no surprise really that, again, this is quite old data now, but it shows that the wards that we usually worry about are the wards that tend to suffer from fuel poverty. And I suspect, as I say, that's pretty similar ongoing. Next slide, please. And here again, just looking at the figures, you can see the sort of difference in levels really. So in South Ward, there's 26.1% proportion. So that's like over a quarter of households in fuel poverty in South Ward, as opposed to Haverstow, which is sort of just over 10%. Next slide, please. So key issues, inappropriate prescribing. So historically, with the preventer and reliever inhalers, we've tended to prescribe too many relievers and not enough preventers. And what we're doing by that is sticking a sticking plaster on it when somebody has an attack, but not dealing with the underlying issue of airway inflammation. So that leaves children with ongoing inflammation, which means that they're very at risk of further attacks. Health inequalities, as we've stated, more children will be affected in deprived areas. Problems with compliance reviews, inhaler technique and education. So there's differences between different practices, differences in whether the face-to-face or telephone reviews or even online questionnaire type reviews are taking place. Difference in experience of the nurses that are providing these reviews, and what the reviews are actually containing. And in terms of education, you know, there's lots of parents being educated about their children's asthma, but then unfortunately, as the children get older and take over their own asthma care, they're not themselves receiving education on asthma, which I think is a really key factor in why that concordance drops off as they get older. There's no such thing as mild asthma, and certainly 2 children who died in our ICB in 1 year, one of them was classed as having mild asthma and had not really touched secondary care services. So even mild asthma can be fatal asthma, unfortunately. We're still not collaborating brilliantly between primary and secondary care. We need to get better at that. And also with the neighbourhood teams coming, you know, that system integration is going to be so much more important. Obviously, for NHS England, digital is a huge focus for the next 10 years, but still we've not really identified a great digital solution to help people with asthma manage their asthma and therefore improve their outcomes. And also, you know, we need to think about the environment around the child. Who's seeing these child day in, day out? Schools, sports clubs, local authorities. You know, we need to make asthma everybody's business. Next slide, please. So this is just one to look at some of the interventions, you know, so we've got real specialist care there, which will go right into, you know, tertiary care, which some of our children have to go to if they want the biologic type drugs. And then we've got right down to prevention, you know, smoking in pregnancy, asthma-friendly schools, you know, creating a good environment around the child, you know, maybe focusing on those preschool wheezers and you know what we need to do there, because you know a lot of them get better and don't develop asthma, and then some of them do. And you know, is there any interventions that we could put in there to reduce that risk? We've got social prescribing, which I think is absolutely key in being that bridge between health and sort of the more social aspects of asthma. and an all age formulary that's based on best practice guidelines that we can all follow, so that we get that consistent approach to prescribing, which is more in line with that European model that seems to be getting better outcomes. Specialist nurses, we've got the national tiered training now, which ranges from tier 1 for non-clinical staff, right up to the higher tiers for our secondary care consultants, and sort of tier 3 for people like me and specialist nurses, and tier 2 for general nurses. And we've got the ongoing asthma on QoF, so it is still there, and there are still some outcomes for GPs to be meeting to try and get maximum points, so financial incentives for GPs. Next slide, please. Yeah, and I'll hand over to Jen.
Sounds like it's Thank you. Thanks, Marcy. I think you've really set the scene amazingly there. I think the take home that I've got from that is that asthma is common. We know how to manage it, but we don't always get it right. And as a result, we have poorer outcomes, which unfortunately aren't getting better. So my section really is just to talk a little bit around some of them system gaps that Marcy had mentioned around awareness, really. So we've had why am I not moving there? 1 minute. There we go. We've had the CYP transformation team in place now for a number of years, which brings together some sort of trying to deliver the National Bundle of Care for Children and People with Asthma, which was published in 2021 now, which sort of was the system-wide interventions that could improve asthma. And it's not just looking at that clinical approach, it's looking around that environment, like Marcy said, around the family and around the child, and looking at more at what we can do preventatively and in the environment, as well as what we can do from a medical standpoint. And one of them elements is the Asthma Friendly Schools initiative, which we launched in Humber and North Yorkshire in 2023. We've had slow but steady progress with the Asthma Friendly Schools initiative. I think in main because we haven't had a really dedicated sort of resource to push it out, but we've got a few schools in North East Links, and there is plans really to try and bolster that in North East Links and get some more schools on board. But the premise of Asthma Friendly Schools is around ensuring that schools have the essentials to support children and people with asthma to thrive in education. So it's not asking them to become asthma experts, it's just becoming more aware of how to manage asthma in the school environment and make sure that they can thrive at school and receive the education they deserve. And that to become an asthma friendly schools, they meet 7 standards really. So it was launched, the background of it's not something that we've sort of developed in Humber and North Yorkshire, it's something that's been ongoing since 2018. And it was part of their recommendations from the National Review of Asthma Deaths, which found that quite a significant proportion of the asthma deaths that they reviewed were preventable. And one of that then elements is around that awareness. And I think, Marcy, you talked about that quite well, in that actually we sort of trivialise asthma, and certainly that's true in schools as well, or has been historically. So it was launched in London, and it was also off the back of some coroner's reports where some children had died, unfortunately, and then deaths had occurred within the school environment. So it was stressing the importance of ensuring that schools are well trained and aware of how to manage asthma. And it was evaluated really successfully, and it's been ongoing in London for some time, and that's why it was included in the national bundle. So we have at the very beginning invited all schools to participate. I think the main thing to say is that it's not mandatory. Schools have a whole host of things that they have to do and have to deliver, and what we're trying to do is sort of bring schools on board and trying to support them to do it, because actually it's a really good thing to do, but we understand that there's lots of other pressures and constraints on schools. So the steps to becoming an asthma friendly school, I hope you can see this. I tried to make it look like a journey, but I don't know if it looks a bit busy. But the first thing we ask schools to do is identify an asthma champion. And now that's there is some more information on the slides, which I probably won't go through in detail. But it's just identifying someone within that school that does a bit of extra training, probably does the tier 1 asthma training, and becomes that coordinator for the asthma friendly schools standards. But they have to have backing and buy-in from senior leadership. It's not just in isolation, but in historically, while we've been doing the project, often that's the SENCO that takes on that role, or someone with admin, or sometimes what often is really common is someone who's just got a really vested interest in asthma. They might have someone in the family that's got asthma, and that they can see the benefit of improving asthma outcomes in schools. We ask them to have an asthma policy, which we have an example template that schools can use and adopt, but actually they normally have a medical policy that's in place from the local authority anyway. But we give them that asthma policy if they want to use that template. That they keep an asthma register that's up to date. And again, this is something that schools generally do, and it's generally statutory. They collect information about the children and people in the schools and what medical conditions they have. We just ask them to be aware of who in school has asthma and make sure that the school, the whole school environment, staff and that know about the children in the school with asthma. Maintain an asthma emergency asthma kit in school. So in 2014, there was some guidance that came out around schools being able to purchase spare blue inhalers for use in emergencies, and that still stands. It's not been updated since 2014. So schools can purchase an inhaler and a spacer. And there are certain things around that guidance that they have to adhere to. So they can't just give it to any child. It has to be a child that has a diagnosis of asthma, and they have to sought consent. But we ask them to maintain an emergency asthma kit. The difficult one one of the difficult elements of these standards is around requesting personalised asthma action plans. Now, Marcia alluded to that sort of gap in quality around the care we give in primary and secondary care, and we know there's variation between young people and children that get an asthma plan and those that don't, and it can be variable. So often schools will say, well, we've asked for it and we don't get it. So we say as a bare minimum, when they are aware of that child having an asthma diagnosis, that they request a personalised asthma action plan from the family, but they also have an emergency plan for in case of an emergency, and that's within the policy as well. And that they have good communication between school and home. So we all know, certainly I know as a parent of teenagers, that what happens in school clearly stays in school until it becomes an issue. And sometimes I ask my kids what they've done and they can't remember. So we just need to know that when they're having an inhaler in school, if they're overusing their blue inhaler, for instance, or they're needing it regularly, if that's not communicated home and then that child's going home and having the blue inhaler, sometimes the parents aren't aware that the control is as bad as it is and that they need a review. So it's about establishing that communication so school and home know how much the child is using that blue inhaler in school potentially, or what symptoms they're having that school may be noticing that they're struggling to involve themselves in PE lessons because they're very out of breath or wheezy. We need that communication and that open channel. And then the whole school asthma training. So the Tier 1 asthma training that Marcia mentioned is available, and we ask schools to do that. And we have quite a high bar for that. We want 85% of school staff trained to manage asthma, because it's not an isolated, we don't want it to be an isolated policy where there's just a number of staff that know how to manage it. We want all staff to know, and it's that making asthma everybody's business approach that everybody in school needs to be aware. And then at that point, they would self-declare and send a self-declaration checklist, and they would be awarded asthma-friendly school status, which is maintained for 2 years. The schools that have done it have been, happy with how it's set up, and they found it beneficial and has, improved their understanding and awareness of asthma. So I'm not going to go through this just a bit of a rundown of each of the standards, but we'll share the slides, I'm sure, at the end. But if you follow the QR link on the page here, that will take you to the e-learning modules if you fancy doing a bit of Tier 1 asthma training yourselves. I'd recommend it. It takes about 40 minutes and it's free and it's quite informative. So the benefits really is improving safety. So by staff being trained to respond effectively to asthma symptoms and emergencies, you improve safety. Better health outcomes, because as I've said, we know that asthma cannot be just treated in isolation from a medical approach. There's a whole system and an approach to it, and sort of the environment around the schools. And we, with asthma friendly schools, there is another piece to this that we probably need to look at in the future, and I'm sure that it would be something we could talk about in the future around sort of air quality around schools. So some schools, certainly in North Yorkshire, have the Safer Streets project going on, where they shut the streets to cars to reduce the air quality, the impact on the air quality at school pick up and drop off times. And it's also like things like schools, if there's a high pollution day, not having the windows open, because that will affect the children with asthma. So there is more we can do around that air quality, I think. Inclusivity of education. So there's no reason that anyone with asthma can't be fully involved in school activities and in society in general, really. So it's promoting that inclusivity. Enhancing awareness, which I think is the really big one. You know, people need to recognise that asthma does kill, and unfortunately we have had asthma deaths in our region, and we're not immune to it, so we need to be aware of it and how to prevent them deaths. I've talked about the stronger communication, and it's recognising that schools' commitment to health for children and young people. So to lead on from that, when Marcia mentioned around the NCMD report, so the National Child Mortality Database report, what was really clear last year that we realised when that report came out was that the 2 asthma deaths that we had in our region, although not included in that study because it was after that, fit that category, those categories on that NCMD report perfectly. Both were young men, both were 15 to 17 in age, both had an out of hospital cardiac arrest, both had been to hospital in the weeks prior to their deaths, and both had had in excess of 20 blue inhalers in the year preceding their deaths. So there was significant signs that their asthma wasn't controlled, and there was significant opportunities to intervene. So off the back of that, we wanted to create an awareness campaign that primarily at this stage is focused on professionals, encouraging professionals to understand that using a blue inhaler is a sign of poorly controlled asthma. And as Marcia rightly said, asthma is an inflammatory disease, and it is treated with a preventer inhaler that contains steroid. The blue inhaler will treat the symptom, but it doesn't treat the cause, and actually overuse of the blue inhaler can precipitate symptoms, make them worse. So the Too Much Blue campaign was launched. It links to our work on the asthma guidelines, sort of to encourage our health professionals and our teams to follow the asthma guidelines and appropriately manage and treat asthma in accordance with them guidelines. So we've got really good evidence that the guidelines that we implemented in the end of 2023 have had a significant improvement on our salbutamol prescribing. So we've been tracking this for a number of years at a national and local level, and we can see, so the red line is Humber and North Yorkshire as a whole, and you can see that when the guidelines was introduced at the end of 2023, that we've seen our prescribing rates fall below the national average for the first time in a number of years, and it is steadily declining. So we know that these guidelines have had a really good impact on prescribing practices. But as I've said, with the 2 asthma deaths that we've had, there is still pockets where this is still going, and there's still lack of awareness that mild asthma is not a thing. We tend to call it controlled or uncontrolled asthma now. And if you're using your blue inhaler, you've got uncontrolled asthma if you're using it a significant amount of times in a week. So these are some of the assets that we've got. You'll see that my background is on. So we've got Team's background, the blue signature bar, which is a hyperlink to the guidelines, and then there's some posters, and it's all available. I think, Lauren, I think you've kind of shared that in the chat. So people, if you want to get involved, you can access them there. What we're asking staff to do is display them in staff areas, use them in team briefings and updates such as this one, and use it on your email communications and your team's background if you're able. And again, the hyperlinks there for to the campaign if you wish. And then I think I'm not going to labour on this too much because I know we've got other things to discuss, but I think, as Marcy said at the very top of this, you will all know somebody in your life or yourself that has asthma. And we know all too often that people continue their lives with poorly controlled asthma thinking that that's normal, and it's not. So if your asthma is controlled, you should be able to carry out your daily activities without restriction. You shouldn't be waking up with asthma symptoms at night or when in the night or when you're waking up in the morning. You shouldn't be missing school or work because of asthma, and you shouldn't be relying on that blue inhaler to manage symptoms. And typically we would say if you're using it more than twice a week, then you need to see your healthcare professionals. So what to do if your asthma control is not good, or you can think of someone in your life that's not got very well controlled asthma, is have a checkup. Everyone should have a checkup at least annually for asthma, and sooner if their asthma control is poor. You should be on a steroid containing inhaler. So gone are the days where you just had a blue inhaler because you had mild asthma. If you've got asthma, you need the correct treatment, and the correct treatment is a steroid containing inhaler, and there's lots of different treatment regimes out there. You should know how to use your inhaler. We know that even in healthcare professionals get inhaler technique wrong, and that's an appallingly high percentage of healthcare professionals that get it wrong, but that's even higher in our people with asthma and their families. So know how to use your inhaler and how to use it correctly, and if you don't know, ask. Pharmacists are really good. If you want, they'll help as well if you want to drop into your community pharmacy and ask. You should have a personalised asthma action plan that tells you what to do if your asthma is getting worse, and you should understand your triggers. And if you're worried, just please speak to somebody. And I think that is me. I have to hand it over to Katie and Holly.
This is where I'll jump in. So you've got me today. So as I said at the start, my name is Di Duckworth-Mills, Head of Children, Young People and Families at Centre 4. And as an organisation, we oversee the element of the social prescribing link worker, working with Marcia, Lauren and Jen, and making sure that we're part of that ecosystem of supporting asthma for children in this area. We recognise, obviously, social prescribing plays such an important part in this, because whilst often asthma is diagnosed and treated from a clinical side, we know that it's also lived out in homes and schools and in those environments. So actually being able to meet families and those children's from some of those clinical and environmental factors allows us probably to have the most successful outcomes in making some change regarding asthma management. So if we jump to the next slide. So when we think about the asthma link worker role. Now, Marcy has touched on this earlier, and I'll use some of the same language because I think it's so important that we see that as the vital bridge between clinical care, the child's home environment, school life, and the wider community. So the programme recognises that asthma control is influenced not just by medication, but housing quality, air quality, access to community support, physical activity, but also a child's confidence in managing their own condition, but also then a parent or carer's confidence in managing their child's condition. So therefore, Holly's role becomes both practical in terms of that relationship with the clinical side, but then also quite relational in terms of how then we expand that into homes and schools and community groups. So some of the things that Holly will do is that focusing on the shift from organisations such as Marcy's and the NHS and things having to treat asthma episodes to actually as preventing them using quite a holistic approach, so preventing some of those exacerbations as early as possible. Now, Holly does this through various ways, and we will introduce Holly shortly. She's going to share a bit of a case study. But some of the ways that sort of manifests as the role of an asthma link worker would be support for children and their families when dealing with housing concerns such as damp and mould. So we know that's quite significant, and actually it's quite significant in more deprived areas. So being able to have that link and provide some element of resource and possible solution within those homes is really vital to managing the condition. Working alongside other services within Centre 4 and beyond, such as for families and youth, to build on this multi-agency support where possible. So this link worker is about connecting with other services that might improve some of those lifestyle changes or provide the best opportunity for them to happen. It's about signposting and linking families, as I said, to different services in multiple areas of their lives. So whether that's schools, youth groups, physical activity, all of those things that might have a healthier impact on the management of their condition. And then working with schools to promote Asthma Friendly Schools initiative and supporting schools in enrolling for this. This is really important because actually if we look at the amount of time that our children spend, most of it is within education. So how do we really formalise some of those links to make sure that for the majority of the day that there is this knowledge and expert understanding in some of the basics of asthma, but also what poorly managed asthma looks like. We often really talk to people about well-managed asthma and actually how to recognise some of those signs when it's poorly managed. If we could jump to the next slide. So as with everything, you need a bit of a place in which to start. And what we've started to look at is kind of RAG rates, because it currently is a closed referral pathway. So we've obviously got a caseload. Some of those will come in at the point of poorly managed asthma. Some will come in with there's more than routine care needed to support, and then some are managing their asthma really well. So actually being able to look at how that asthma is affecting every child, it will be different depending on the management of the condition. So the RAG rating allows us, I guess, to assess support for young people to ensure we're able to front load more support to those in need. So obviously some of those critical caseloads will be the ones that are experiencing exacerbations of their asthma, unplanned attendances at A&E and things like that. So making sure that we have a pathway that's more intensive to support some of those needs of the child and the family at that point. And then, as I said, we're looking at this sort of amber RAG rating, which is focusing on that. We need more than routine care. So we're looking at, that might be an education piece, it might be more focused around school, and actually an asthma care plan within school, because that might be where we see more episodes of asthma, or it could be that actually there's an over-reliance when at school, and school think that that's well managed because they're using their inhaler, but actually we know that that's not necessarily the case. And then for well-managed asthma, we don't just want to sort of sit on our laurels there, but actually there are still signposting and things that families and children can do, particularly around education and that transition point when a child starts to take more responsibility for their condition. So it might well be managed quite well under the guidance and care of parents and carers, but actually when a child hits 16, 17, how prepared are they then to carry on that well-managed aspect of their condition? So that's just a little bit of an overview of how we're looking at the referral pathways, and then that determines some of the work that Holly picks up with some of those young people and their families. We can jump to the next slide. So as part of that RAG rating, as with everything, it is good to see the impact of intervention before and after, because I think it starts to give us a bit of an idea in which areas there might be thematic things like actually well-being has come out, or parent confidence. So then we start to understand what kind of literature or information we need to be providing going forward. So in terms of our impact recording, when we go on that sort of service user journey with the parent and the child, is looking at those four main areas, which is around well-being, parental confidence, but also attached to that is the child's confidence, school factors, and then home conditions. And it starts to give us this sort of holistic view of how they're feeling in each of those areas, and then that sort of determines some of the support pathway as well. And then we do that at the end to see whether we've had some distance travelled, because it's also important for the child and the family to feel an element of success in some of the interventions that have been put in place as well. Can we jump to the next slide? So this is where Holly is going to give a bit of an essence, and I guess bring some of the social prescribing element to life through a case study, and she'll touch on a couple, but particularly one main one, and it will give you an opportunity to hear from Holly herself as the link worker. So I'll hand over to Holly.
Thank you, Di. Yeah, so I'm looking, we've sort of discussed a few different case studies that I can bring to the
sort of table. And I know there was one that we was really quite pleased with, that I managed to pick up a case where a sibling was actually asthmatic, but not hadn't been sort of on the coding on the system 1 or whatever with Raj, hadn't been coded properly by a previous colleague that worked there. So when I sort of was speaking to the parent, it was established that the program's probably not brilliant for the son that I was ringing about due to some learning needs, but would be maybe more beneficial for her daughter. But we didn't have the information about the daughter, so I passed that on to Marcia, you know, was in touch with Raj, and we've sort of got that into place now so that she can be followed as well. Another case study that I've sort of come across, and it's actually come across since we'd first sort of introduced that case, is I'm currently working on it as well, obviously with the parent, is a lady who's in a LHP property, and she's got quite bad damp in her home, mold as well, but quite bad damp to the point that the paint's falling off the wall. She's reported it multiple times to LHP, nothing's happened. So I've gone in and sort of, you know, we can report it to the council and we can get some support there. So I've gone to the council, and it turns out the council actually have only just done what's called a bleach wash, and it sort of cleared the mold for a little bit, and then that's come back. And then as I've sort of taken my role as chasing that up, well, the council stated actually it needs to go back to LHP because it's not up to them to sort. Obviously, with this being an LHP, you know, social housing property, it does come under the new Arabs law legislation that's just come into place in October. So we're struggling actually to get that support in. So I've spoken to the mum this morning just briefly. She is chased up with LHP to try and get an appointment for them to come and have a look at it again, but they're still not answering her. I've chased a couple of times with LHP and with the council, and I've not had a response either. So that's where we're sort of, it's becoming quite a meaty case into, obviously, as we all know, the law that's come into place is because a 2-year-old died due to being in a house, a home flat with social housing that was riddled with damp and mold. And that's why the legislation's come into play to sort of cover that for children that have asthma. Well, family, you know, generally it's not healthy living in a house like that, but to be covered with social housing. But now we're finding that in sort of deprived areas in this area, in North East Lincolnshire, is that actually that's not being picked up yet, and no one's actually jumping to support like I thought would be the case, especially with the new legislation coming into place. So it is something that I'm obviously continuing to work on. I'll continue to sort of update, and hopefully we'll get a bit of a better outcome. But for this family, it's sort of a 2-bed house, mum and 2 girls sharing a room, and she's basically being passed from pillar to post at the moment. So I'm trying to sort of come in as that professional to guide and support, but I'm also running into problems with LHP and with the council. So it's quite a big, you know, case study that's come right off the bat of, you know, this pilot scheme. So hopefully we will sort of get a positive outcome from that. It just depends, I suppose, how long it's going to take and how quickly these services are going to sort of jump up with that and offer that support and what we can do moving forward. Obviously, there's only so much we can offer as the pilot scheme, but, you know, we have got a little bit of funding with bits and bobs, but it's just sort of recognising that we all actually probably live in quite a privileged sense of being able to afford our energy bills, afford costs of things. Sort of, I mentioned to them all about dehumidifiers that we could maybe provide, and it was not necessarily the cost of purchasing a dehumidifier, but the cost of actually running one and affording to pay for bills to cover that. And it sort of opened my eyes to, you know, being in a privileged position of being able to afford your bills and not questioning that. But obviously then there's families in our area that are living where they actually can't do the things that maybe help promote the air quality, home quality for living in them, you know, living with asthma and getting that support from services that are there and available. But if you can't afford to run sort of these things that could help you potentially, that's, you know, that's coming to be a bit of an issue as well. So hopefully, you know, next time we meet, I can have a bit more of a positive outcome on that one. You know, I'm working towards it, but it's looking to be a bit of a tough one just to start with. So yeah, it's a good piece of work. Hopefully at the end, you know, the outcome will be positive.
I think this sort of crystallizes why this work is so important, actually. Yeah. So looking at the first thing that Holly shared is actually there's somebody now on a clinical pathway that weren't previously recognised as a sort of having the condition, which is massive in such an early stage of the programme. And then you look at this as actually movement is happening with big organisations and housing to better improve the conditions, and that work wouldn't have happened without the instigation of this programme. So we are hopeful for that positive outcome, but it's sparking some of these, you know, really important and exciting conversations to say we can do all of this actually still in this home. We need the support of other organisations. Marcia?
Yeah, I think that's what I was going to say. In the end, with this project being so new, every time we do something, it's sort of like you're doing it for the first time, isn't it?
Yeah.
So, you know, when the funding for Holly was agreed and we started, at first we were sort of like, you know, we had to completely plan from scratch, you know, and for Holly, who'd never done any clinical work, she did her asthma training, but obviously to then go in and start having conversations about clinical things with families felt really new and really difficult. As well, like my initial vision for this was that we would ring people up and we would bustle into their houses and do these home checks, and it would be extremely helpful. And actually, you know, we've had to pivot on that, because for some families, you know, there's high levels of shame, there's high levels of mistrust of what they see as authoritative healthcare, even the word social prescriber. For a lot of our families who've had social services involvement can be a real barrier, and there's suspicion, you know, why do you want to come into the house? So actually what we've had to do is take a bit of a step back with it and say, okay, we'll do a bit more softly approach with some of these families, build up that relationship and trust first, and then get in. And you know, the LHP issue, this will be really, really tough, this first case. You know, there'll be all sorts of resistance. Who the heck are you? You know, like, why do we have to listen to you? Blah, blah. You know, we'll perhaps have to get a bit of the, you know, the meat of the kind of ICB behind it and all work together. But actually, the second time you go with a case like this, hopefully it'll be a bit easier. And the third time, it'll then be a habit, a process, won't it? So it's always hard to push that door down that first time and kind of battle your way through a new kind of process or kind of thing. But I think we just need to be absolutely, you know, on it with this, because this is exactly why we set up this project, isn't it? And how the heck would these families cope with this kind of, you know, who has the capacity, you know, if you're living in a situation like that and probably dysregulated and struggling with all kinds of life stresses, who has the capacity to be able to then battle with housing about getting this sort of problem sorted out? And this is exactly why children are running into difficulty with damp and mold, isn't it? So I think it's fantastic work. Sorry, I've harped on for ages. I'll be quiet.
No, I think it's a brilliant point, Marcia, because as a community connector, is that what we think at the heart of being a link worker is actually there's now a conversation that didn't exist before, that the parent or carer didn't have the pathway, the tools or the skills to make that conversation happen. And we are already much further down that road than what the parent was a couple of months ago. So I think in that sense that these are some of the positives that we can capitalise on, that we can learn, and really actually, I'm going to say it because I'm an eternal optimist, but that will make systemic change in how the system operates and how it engages around understanding asthma beyond the clinical side of it. So I think, yeah, it definitely crystallises some of the work of the social prescribing link worker. Could we jump to the next slide? Because that actually brings me on quite nicely to how we think about some of those future plans, and particularly how we continue to sort of galvanise on some of these early successes that we've had, and really start to think about the caseload that we will continue to work with. So some of those future plans are really sort of thinking about how we continue networking with other local agencies to improve support for service users, onboard local schools in preparation for the Asthma Friendly Schools accreditation. So we absolutely, Jen, see ourselves as part of that ecosystem of making sure that our work with schools leads to some of those schools in the area becoming asthma friendly schools. Increasing awareness of the offer in the local community through marketing and events. And this has been really interesting, and actually we've got good early intelligence now of how different it is to work with children and families from a social prescribing perspective. Parents and carers are the current gatekeepers to working with the child. And so what we've really started to learn, they're obviously not the ones with the condition, but they are the gatekeeper. So how we constantly learn and adapt our comms approach to make sure that the parent feels the value of this extended support beyond the clinical side, and then in the hope that they're much more receptive to us going into homes, completing a home checklist that will really change and help some of the control of the asthma in the home. We're going to explore opportunities to expand the programme. So we're obviously in conversations with Marcia around could this grow? Could we look at the caseload and that referral pathway and how we work on that? And then regular operational catch-ups. I think we really want to ensure efficiency, a really solid QA process, capturing some of these case studies, and then making sure that we're in line and talking some of the same language as the clinical side, and then working with Jen to make sure that from the education side, and hopefully, I think us all working together, which we're already seeing, allows us to achieve some of these outcomes for young people in this area that we know are in need of it in regards to well-managed asthma control. So that's a bit of a whistle-stop tour on the social prescribing side, but I think hopefully just reiterate some of the earlier messaging that we've had, and our commitment to supporting families within the area.
Thank you, Di. Excuse me, sorry, took a bit then. But just really interested, isn't it, to bring it to life. I know obviously we've met a few times now discussing about the project and the potential it has to expand, and I think it's fantastic the work that's been started, and let's hope we can make those connections into the local authority around the issues we're having with housing. So that's sort of next step. So excellent. So I'm just going to touch on a couple of things, just to highlight some of the links and things I've been putting into the chat as the presenters have gone through. So linked into the chat is the Asthma Friendly Schools initiative. So if anybody's interested in finding out more, please click on that link. Also around the training, it is free, it's e-learning, you can do it anytime, any place and at your leisure. So please do encourage staff and people you work with to go and access that training. The clinical guidelines as well for any practitioners out there actually working in a clinical capacity have also been put into the chat and are available, and I suggest that you go along and look at that and how you integrate that into practice. And I also wanted to just touch on the Healthy Together website. So if you could just click for me for the next slide, just to highlight to colleagues that don't know about the resource that's out there, the Healthy Together website. It's absolutely fantastic. It's got all the information across the Humber and North Yorkshire, and it's not just for professionals, it's also as an aid for parents, carers, young people, as a way of you identifying advice and seeking that out. Lots of practical advice on there and resources and educational materials and videos, and it's a really good way to try and keep that consistency of messaging. So just really encourage our colleagues to go on there and have a look at the resources that are available. There's more than just asthma, there are other health topics on there as well, so please do go and check it out. Jen, do you want to come in?
I just wanted to add, just while it feels like a right time to mention with the Healthy Together website, we are in the very last stages of transitioning to a national site. So what that means in reality is not a lot really practically for people going onto the website. They'll see the same information and it'll be localized. But when it transitions over, it will ask you if you're a patient or the public to put in your postcode and link it to your GP practice. And if you're a professional, it'll ask you to where you work and what your profession is, so that it further personalizes that experience on the website. But sometimes people are a bit reluctant because they think that we're gathering it for other means, but it's just to personalize and the site to where you are and the location you're at. So that is coming, we're hoping, in the next couple of weeks before Christmas. So it won't change in practicality, but there is just that slight little tweak that's going to be on there, and loads of accessibility features, sort of interpretation resources, accessibility resources and stuff like that. So I just wanted to add that in while you were talking about it.
No, thank you. Thanks for the update. People find that useful and know that we're not going all Big Brother. Okie doke. And then on the final slide, I believe it is the final slide. Just some summaries about next steps and how you might like to get involved in the programme. So we'll welcome anybody to come along, share your expertise. So please do express any interest by reaching out to us on our navigo.hosting email address there on the slide. We have trialled our first edition of an asthma-friendly newsletter. And that went out in October, and we hope to have another newsletter with updates going out in the new year. And then that QR code there, the last point here on the slide, is for the North East Lincolnshire Health and Care Partnerships LinkedIn page. So we are regularly posting on there about updates across the wider health and care partnership and all the initiatives we're involved in. So if you want to find out more, it's a really good one-stop shop for you to find out a little bit more about what we all do in our roles across the health and care partnership.